today's session is very special one because we have got very eminent speakers from all quarters of India. Dr. Laxmi Vaj ma'am from Mumbai, Dr. Madhuri Lokapur ma'am from Pune, from Dr. Sarita Singh from KGMU Lucknow, which is a very prestigious institute also. Dr. Narinder from Chandigarh. He has been trained not only in India, he has done his PDCG from BHU, Varanasi, as well as he has been trained from Canada in pain and palliative care. And Dr. Vinay Soumya is with us as the moderator for this program, and we are going to have try to give you a comprehensive picture of cancer pain management and different scenarios of cancer pain management in today's program. I am personally sorry for the technical glitches which you are facing. Because of that, we are slightly late from our scheduled program, and I hope that you all will find this program useful in their day-to-day practice, because we are going to discuss about the things which are actually being done, not absolutely theory. So it will be, I hope, that very useful for all of us pain physicians who are working in the field of total pain relief, that is the pain medicine, and where we do take care of a lot of cancer patients also, because most of them are not worried of their dying one day, but they are worried of their suffering. So is the family. So I hope that this webinar and panel discussion will be a किसी का माइक खुला हुआ है, प्लीज बंद करिए. डॉक्टर विनय सोमया, डॉक्टर नरेंद्र, डॉक्टर मोहित. Okay, मोहित का तो नहीं खुला है, sorry. I would like to say a word about this MedWiz platform also. This is an indigenous platform, online platform made by a group of 4 doctors. Mr. Martin from MedWiz is here to support us, and we have been using this indigenous platform for our webinars in the Self-Dependent India initiative. So thank you, ma'am. Thank you, ma'am. Dr. Sarita, ma'am. So are we ready with our program? Should I start?
Yeah, you can start.
So I take the liberty of all of you and permission to start the program and give the charge and baton in the hands of Dr. Soumya. Dr. Soumya will say a few words and then invite the first speaker. So Dr. Soumya, please.
Today is our 8th webinar on cancer pain and a comprehensive management. And as we are already late by 15 minutes, so I directly invite Dr. Narinder Pal Singh. He is senior consultant in MMU Super Specialty Hospital, Mulana. And his area of interest is cancer pain and regional anesthesia. He has published 25 international publication and national 3 publication he has, and he was awarded with clinical fellowship at Asan Medical Center, Seoul, South Korea, awarded clinical fellowship at University of Manitoba, Canada. And his topic is comprehensive assessment of pain and pharmacological management of cancer pain. So I request Dr. Narinder to speak few words and present his slides.
Yeah. Thank you, Dr. Vinay Soumya, for your kind words. I would like to thank the organizers for giving me this opportunity for this web presentation. So good morning, everyone.
Good morning, yes. Dr. Narinder. Please open your webcam also.
Yeah, I am doing it.
In the meantime, I would like to mention our supporter of this webinar. This is Johnson & Johnson, and we are happy to have Ms. Meenakshi and Mr. Sutirtho from Johnson & Johnson in this webinar with us. So we will have their opinion also about the program after the program. So welcome, Sutirtho and Meenakshi.
Thank you so much, sir.
So we doctors by and large are very poor with technology, especially the digital technology. So I hope that nobody will find it offensive that we are having slight difficulty in logging and sharing our presentation. Yes, yes,
present
Dr.
his
Somya.
slide. I will like to share some facts about the cancer. Cancer is the
Yes.
second leading cause of death globally and responsible for the estimated 9.6 million deaths in 2018. Globally, about 1 in 6 deaths is due to cancer. Approximately 70% of deaths from cancer occur in low and middle income countries. Around 1/3 of deaths from cancers are due to 5 leading behaviors and dietary risks: high body index, low fruit and vegetable intake, lack of physical activity, tobacco use, and alcohol use. Tobacco use is the one of most important risk factor for the cancer and responsible for approximately 22% of cancer deaths. Cancer-causing infections such as hepatitis and human papilloma virus are responsible for up to 25% of cancer cases in low and middle income countries. Late stage presentation and inaccessible diagnosis and treatment are common. In 2017, only 26% of low income countries reported having pathologies services generally available in the public sector. More than 90% of high-income countries reported treatment services are available compared to less than 30% of low-income countries. The economic impact of cancer is significant and is increasing. The total annual economic cost of cancer is in 2010 was estimated at approximately 1.16 trillion US dollars. Only 1 in 5 low and middle income countries have the necessary data to drive cancer policy.
Yeah, thank you, Martin. So, good morning, everyone. After the technical glitch, I will be starting on my topic for today, that is comprehensive assessment and pharmacological management of cancer pain. So, as you might be knowing, that the prevalence of cancer pain is very high in the patients. It is from the different studies, it has been raised to 24 to 60% in the patient on active anti-cancer treatment, whereas more than 80% of patients will have this cancer-related pain due to advanced cancer. Satisfactory control of cancer pain remains the single most element in the palliative care setting, as a failure to pain relief is a major threat to the patient's quality of life. So despite being significant medical, pharmacological, and technological advances, the prevalence of cancer pain is still unacceptably high. So why do we need to assess the pain? That we have to see. So as you can see, the cancer-related pain is not homogeneous. It has got different etiologies, different pathological mechanisms which lead to different types of pain. So total pain assessment is essential for the satisfactory cancer-related pain management. So as it encompasses range of different pain conditions because of different pathologies and characterized by different etiologies and pathological mechanisms. So for the proper assessment of pain, it is very important to understand what is causing the cancer-related pain. Before we talk about how to assess the pain, we need to know what are the possible etiological causes for the pain. So the first important step is the assessment of cancer-related pain. It should be brief, precise, multidimensional, and it will be specifically targeted to the patient population to be assessed. So what are the possible causes which can cause the cancer-related pain? It may be because of cancer itself, that can be because of local mass effect, or because of paraneoplastic phenomenon. It can also be because of different interventions as well as treatment complications like radiotherapy-induced mucositis and chemotherapy-induced mucositis as well. So it can also be because of the associated debility, because of the medications and cancer effect, that may be because of constipation, muscle tension, and it can be because of unrelated causes to the cancer. So coming to the types of pain, it is background pain, persistent background pain that can be controlled by controlled around the clock analgesia. Whereas one thing is breakthrough cancer pain. That is not because of different reasons. It can be spontaneous with no apparent trigger. It can also be incident pain that is predictable, as well as some unpredictable character is also associated with this incident pain. So end of dose failure is not the incident pain. It is it is the failure to control the persistent pain due to unavailability of round-the-clock analgesics. So the new term has come up for the breakthrough cancer pain, that is transient cancer pain exacerbation. It is usually rapid in onset, severe in onset, intensity, as well as self-limiting. It has been shown that it starts around 3 minutes and it peaks its intensity around 30 minutes and lasts around 50 to 60 minutes. So for this short-lived pain, which affects the quality of life of the patient, we should go for the rapid and short-acting opioid to control this breakthrough pain. So coming to the mechanism, there are different mechanisms which can cause the cancer-related pain. That may be because of nociceptive because of visceral somatic pain that can be resultant of pain receptor from the sensory nerve ending, maybe because of hepatic capsule stretch or because of bony metastasis. There are numerous causes for neuropathic pain, that is because of cancer infiltration as itself from the central and peripheral region, or it can be sympathetically mediated or mixed neuropathic pain that can occur due to cancer. So as a concept of total pain, not only these nociceptive and neuropathic elements are there, there is also psychological elements which come into play. So there is a multifactorial nature of this pain, not only because of somatic or neuropathic, there are psychological influences, there is financial concern, loss of work, and there is fear of death. So in total, we have to see the pain as well as suffering, which comes as a total pain. We have to assess the total pain of the patient. So coming to the hierarchy, how do we assess the pain? First, we have to establish a procedure for the pain assessment. So repeated attempts should be maintained to obtain the self-reports. We have to search for the potential causes or pathologies of pain that may be malignant or because of non-malignant reasons, and also look for pain behaviors and ask the family members about the pain-related questions. And we should also consider and attempt an analgesic trial to potential benefits outweigh the risk. We have to use behavioral assessment pain tools as accessible, and this pain has to be reassessed at the time at different times, and we have to document it as well. So coming to assessment as well, we have to see ask for the patient few questions, ask for the sockets like site, onset, character, radiation, associated symptoms, times, exacerbation or relieving factor, as well as severity for the patient. So apart from these, during this assessment, what are the clinical important questions we have to ask? So 4 clinical important questions we have to assess from the patient's history, that is current pain level, average pain level, what is the worst pain that patient is suffering, and how are the medications affecting this pain relief. So how do we quantify this thing? There are certain measurements we have to do, like scales. Different scales are there: numeric rating scale, visual scales, as well as descriptive scale like mild, moderate, severe, and certain outcome measures we also can follow, like how is the pain intensity, how is the distress from the pain, whether there is a pain relief from the medication or interventions from the daily quality of life. But we still don't have the universally accepted tool to measure this. Although we can use brief pain inventory or short form Magel pain questionnaire, but there is certain cancer-related pain tool assessment which has been partly validated or completely validated, like Edmonton classification system for the cancer pain prognostic tool, or pain management index, as well as opioid escalation index. So out of these, the most commonly used are the pain assessment tools are the chronic pain assessment pain prognostic scale that is comprising of 4 factors like numeric rating scale. Then we have to see for the functional assessment of cancer pain, daily oral opioid dose more than 60 milligram, and presence of mixed pain is there or not. With this, we can quantify the patient whether it's a good prognosis, intermediate, or poor prognosis. The other scale which we are using more frequently than cancer pain progression scale is Edmonton classification system for cancer pain, in which we have to see the primary aim of this is to predict the response to treatment. It contains 5 domains, that is pain mechanism, incident pain, psychological distress, whether there is an addictive behavior or any change in cognitive function with the ongoing medications. So coming to the barriers, there are so many barriers to the effective pain management to the cancer-related pain. First is a physician-related, and then again is a patient-related and the system-related. So the physician-related, there is gaps in the knowledge of the physicians, and as well as negative attitudes towards the prescribing opioids and inadequate assessment skills to the patients. So according to a study, it has been shown that 76% of the physicians have a low sense of competence in a patient chronic related pain assessment, as well as 61% have reluctance to prescribe the opioid because of fear of addiction, tolerance, as well as side effect to the analgesics. So coming to the patient fraction, patients are also reluctant to report pain because of the concerns of distracting physician for treating the main cause rather. So they are also reluctant to take medication because they are worried about their side effect and their addiction. So that leads to a poor drug compliance for the patients. Coming to the healthcare system factors, there are so many restrictive factors like restrictive regulation of controlled drugs, and availability and accessibility of the available drugs is not made to the patient. Patient has to travel a lot to access these drugs. And apart from the morphine, which is a gold standard from the WHO point of view, all other treatment medications are costly. And the low priority is given to cancer-related pain treatment. Although priority has been given by the cancer treatment, but cancer-related pain treatment is very low on the priority of the healthcare system. So this assessment should not be one time. We have to assess and reassess and document about the amount of pain relief, what is the duration of pain relief, and what about the breakthrough pain, that is transient cancer pain exacerbation, is there in the patient or not. So coming to the challenges, after all the discussion there, we can see about the challenges of the pain assessment of cancer-related pain, because there are multiple pain-related pain mechanism playing into interplay, and there is individual differences in the sensitivity of this pain as well, and lack of universal classification system, and we don't have objective testing modalities. Only we have to rely on the subjective complaints of the patient and time constraint of the staff as well to assess and reassess the chronic cancer-related pain. So after having the comprehensive assessment of the cancer-related pain, coming to the pharmacological management, we have to chalk out the plan with the patient-centered plan with the help of the family members who have the multimodal plan for the cancer-related pain management. So in this, we have to set the appropriate expectation of the family, patient as well as family member, that will lead to better patient satisfaction and more adherence to the treatment. So even after since last 40 years, since the opioids are coming into play with the cancer pain, pharmacotherapy remains the single most important treatment option apart from other interventional as well as complementary therapies. Pharmacotherapy is still the most important option to the patients. So what are the goal management of cancer-related pain management? So it's an accomplishment for all the physicians to eliminate the cancer-related pain altogether, but it's very difficult, and so we should reduce the pain at least by 50% by keeping all the side effects like sedation, respiratory depression, nausea, vomiting constantly at the bay. For this, we have to use the most appropriate pain regimen, taking into consideration of the patient's age as well as hepatorenal functions. So as age-old principles of pharmacotherapy, it should be given by mouth. No parenteral drugs should be allowed apart from the acute control of the cancer-related pain. It should be given round the clock, and it should be given by the ladder. But pain physician has to see at what step the patient is fitting, and patient treatment has to be individualized with the help of the adjuvant drugs as well as therapies. So coming to the pharmacology itself, there are certain drugs we can use like non-opioids, NSAIDs, as well as acetaminophen that has been used for the initial stages of pain, but hardly these are used alone. So there are atypical opioids which help in controlling the cancer-related pain, that are tramadol and tapentadol. These are opioid receptor as well as SNI receptor activist, so that can control the pain. And cannabis, there are certain trials are going on that the medical marijuana should be legalized to use for the cancer-related pain as well. And certain adjuvant drugs like steroids, antidepressant, anticonvulsant, and biphosphonates, which are helpful in controlling the pain. But the mainstay still remain with the opioids to control the cancer-related pain. So coming to the NSAIDs, all might be knowing it inhibits cyclooxygenase, COX-2, COX-1 inhibitors are there. The COX-2 have less side effect, only with the GI and platelet function. Rest, all the effects are there. They don't have any ceiling effect. So coming to the adjuvant medications, we can use anticonvulsants at the dose mentioned that will decrease the neuropathic pain. Antidepressant will improve sleep as well as appetite along with the decrease in the neuropathic pain. Antihistaminic will help in itching. Steroids will help to reduce swelling of spinal cord compression as well as hepatic capsule enlargement that can be controlled of. Neuroleptic and cytomimetics also help for the general well-being of the patients. So coming to the opioid pharmacotherapy, we have two groups of drugs, pure opioid aconids, in which we can get the weak opioids like codeine and strong opioids like morphine, oxycodone, methadone, fentanyl. There are other class of drugs we can use for the opioid management, but the mainstay still remains on the pure opioid agonist. So and agonist antagonists like pentazocine, nalbuphine, and buprenorphine can be used, but they demonstrate ceiling effect, and they can also precipitate withdrawal symptoms because of the use of the pure opioid agonist. And these agonist antagonists have dose-dependent psychomimetic effects as well. So coming to the administration, how to administer these drugs. There are various routes: oral, subcutaneous, parenteral, transdermal, transmucosal, or rectal. But in the cancer-related pain management, oral route is the preferred route. Transdermal route is used when patient is not able to take the medication orally and patient have stable pain in as well. Rectal route for the short term we can use for the patient with severe nausea, vomiting, or any GI pathology. So IV route is always used for cancer-related pain emergencies. So what are the basic rules of opioid administration? So basically we have, our goal should be controlled pain. Controlled pain, we can say that the patient require 3 or few rescue analgesic during the 24-hour period. We can quickly escalate the dose to control the pain. And then for the opioid agonist, there is no maximum dose. You can go to any level, but you have to weigh the balances of the effect as well as side effects as well. Side effects usually initially there will be there, but that will accommodate within 7 to 10 days. But if those side effect appears, we have to aggressively treat them, especially the bowel regimen for nausea, vomiting, and constipation. So oral or transdermal route are preferable. We should start with immediate release formulation till the pain is controlled or stabilized. Then we can go for the long-acting formulations. So around the clock for the constant pain, the fixed dose of interval drugs should be based on their half-life of the agent, whereas breakthrough pain treatment, which are used for rescue pain, should be based on the time to peak effect. So this is the titration scheme. We can start with the initial fixed dose as well as rescue doses available to the patient. If the pain is controlled, then we should not change. We can continue with that regimen. But if it is moderately controlled, like 25% of the pain is controlled, then we have to escalate the dose of the opioid with the 25%. If severe pain still persists, we can directly increase the dose to 50% around for the 24-hour opioid requirement. So coming to the opioid-related side effects, with the acute administration, patient can have sedation, constipation, nausea, vomiting, pruritus, as well as urinary retention. Whereas tolerance and physical dependence always develop after the chronic administration of opioid for the cancer-related pain. It can also lead to opioid-induced hyperalgesia, where dose of the opioid has to be increased to control the pain. And there is the constipation is a side effect which cannot be decreased by the chronic administration, like sedation and nausea, vomiting can accommodate, but not the constipation. It can also lead to other side effects like hypogonadism as well as immunosuppression. So how do we treat these adverse effects? First thing is opioid reduction or cessation, if it is possible. Like in cancer-related pain, I think it is not possible. So we should have to go for the symptomatic treatment, that is regular laxative or stool softener, make the antiemetic treatment to the available to the patient, and all the patients should be warned about sedation and dry mouth, which has to be taken care at the starting of the opioid therapy. So we can also administer a specific side effect like naloxone, which is, if given orally, it is poorly absorbed and reduces the local side effects of the opioids which the patient has to take for the cancer-related pain. The other thing we can do is opioid rotation. So what is opioid rotation? It is a substitution of the initial opioid which the patient is taking with another opioid to obtain the balance between pain relief as well as the adverse effects. So what this opioid rotation utilizes, it is the inter-individual variation about the different drugs and incomplete cross-tolerance about the among the different opioids. So we can, like patient is stable on morphine, but side effects are there. We can replace it with another opioid so that there will be less side effect and more pain relief will be there. So methadone has a particular role in this opioid rotation. Only side effect of the methadone in the opioid rotation is a renal failure. Like in renal failure patient, methadone metabolites of methadone cannot be excreted and it can cause to the different side effects. So this conversion, how do we do this conversion of opioid rotation? We have to use equianalgesic chart, but it should not be purely mathematical. It also consider previous opioid therapy. What are all the current concurrent medication patients are taking, and what are the specific side effects which existing opioid is having? So coming to equianalgesic dosage, Most of the echoanalgesic doses compare the specified to the specific doses of morphine. These are rough estimate. Physician has to take the consideration that these are rough estimate. He has to fine tune as per the patient. And there is also considerable inter-patient variability amongst the opioids. So general rule is find the echoanalgesic dose, decrease by 25%, and give it to the patient. That is because of non-cross resistance that present amongst the different opioids. So coming to the analgesic ladder, age-old analgesic ladder, which WHO is giving, it is just for the guidance of the pain physician. The physician has to decide about the patient's severity of pain and fits the patient into any of the ladder. It doesn't depend that if patient is coming, you have to go with the step 1. If patient is having severe pain, and you can directly go into step 3 or step 4 if it is required, and physician is thinking that nerve blocks or epidurals will help, then go it for at the first step rather than taking it as a full step for the patient. So coming to the individual opioids, morphine, this is the gold standard by all the guidelines, WHO guidelines, all the guidelines. The morphine has to be given. It is a cheap drug. It's a pure agonist in the spinal cord, brain, as well as periphery. It got metabolized in the liver to morphine 6 gluconate and morphine 3 gluconate. So the later one accumulates in the patient with the renal function. We have to use carefully in the patient of renal functions. So initial starting dose is around 10 to 15 milligram 4 hourly, and then we have to titrate as per the titration schedule. So introduce sustained release formulation once you know the total opioid dose in the 24 hours. IV use is always used for the acute titration, not for the maintenance therapy. So these are the patches. When the patient is not able to take the oral drugs, we have to resort to this fentanyl or buprenorphine transdermal patches, although they are costly for the maintenance of the patient. But sometimes these are the only things available for the cancer-related pain management. So the transdermal fentanyl patch indications when the patient is not compliant or not able to take the oral medication because of the cancer itself or any other pathology. When the physician thinks that there is a chance of drug abuse or cognition functions are deranged, then these transdermal patches should be used, like 12.5, 25, 50, even 100 microgram patches are available, but not in India. So the duration of action is around 72 hours, easy and convenient to use. The patient doesn't need to remember when to take the medications. But the disadvantages with the transdermal fentanyl patches, it's very difficult when high narcotic doses are used because number of patches has to be applied, and that's not advisable. And certain patient, like thin patient with very little subcutaneous tissue, it's difficult to administer the requisite dose with the transdermal patches. So another thing is it's agonist antagonist buprenorphine that is also used to be having the transdermal patch. It has been shown by network meta-analysis. Recent network meta-analysis has shown that transdermal buprenorphine patches are preferable in the patient with renal impairment in comparison to fentanyl patches. So these are also used for the non-compliant patient or drug abuse or cognition issues. 5, 10, 20 microgram per hour release patches are available for the cancer pain, but for the detoxification of opioid therapy, 37.5 microgram patch is also available. So duration of action is 1 week, easy and convenient to use as it is agonist antagonist. So chances of respiratory depression are very rare. So difficulty same, like difficulty with high doses and thin patient with less subcutaneous mass. So thank you for the presentation. Any questions are invited. Thank you very much.
Thank you very much, Dr. Narinder. It was a nice talk about the basic assessment of pain and its pharmacological treatment. Now, our second presenter is Dr. Madhuri Lokapur. Topic is role of intervention in cancer pain management. That is fourth step of ladder. I invite Dr. Madhuri Lokapur. She is presently working as a consultant in pain management and palliative care, Jahangir, Ruby Hall Clinic, MJM Hospital, Assistant Professor, Pain Clinic, BJ Medical College, Pune. Her area of interest is chronic and cancer pain, and she has published Handbook of Pain and Palliative Care Medicine book. And her achievement, she was president of Indian Society of Study of Pain and got prize Susen Raj Pain Physician of Year Award 2013. I request Madam Lokapur. Madam.
Hi,
Please.
good afternoon, everybody. Can you see my screen, which I am sharing now?
No, ma'am. It is not there.
Share the screen again.
Maybe you could have some question answers for the previous talk in this time.
Dr. Soumya.
All right, I'm back.
Ma'am, no questions still for about the previous talk. They are thanking for excellent talk, Dr. Narinder.
Yeah, thank you very much. Thank you, Dr. Soumya.
Can you see something now? Can you see the screen?
It is not shown.
No, ma'am.
Come on.
Screen share again, ma'am.
Everything worked fine in our trial, and I don't know why they should go.
It happens, ma'am.
Okay, I think you just continue with the next speaker if they can, and we'll see if we can come back.
Okay.
Ma'am, you try once more, and then
Okay.
otherwise we will go to Dr.
Shift
Laxmi
to-
Vaj, ma'am. You are presenter, ma'am. You try the sharing.
Okay. It doesn't seem to connect with you guys because this blue button, it is not becoming on at all. The share ka button jo tha na in cancel and share, when I'm sharing my entire screen, that share button is not lighting up at all.
Martin?
One
Martin?
minute, sir. 1 minute.
It says error, permission to access was not granted.
Yeah, ma'am, the screen sharing option has been denied. I have made you the presenter again. Ma'am, can you please see in your search bar on top, there is a mic shown. Search bar on the top, there is a mic shown, or there is a square icon shown. Can you click that, ma'am?
About share screen, right?
So, yes, ma'am.
My part is
Share
done,
screen.
and please that you all should.
Okay, I have pressed on the share screen.
Okay, now what is it coming, ma'am?
Doesn't do anything, and after a while it just says key permission was not granted.
Yeah,
Error, permission to access not granted.
ma'am, in your search bar, where
Which search?
Ma'am, search bar of the browser. Search bar of the browser.
search bar,
Okay.
can you see a mic? Can you see a mic there?
The search bar of the browser, I don't see the mic. No.
No, ma'am, there will be a mic, ma'am. On top, there will be a mic shown. If you click on that, it will show you that the permission to share screen was denied. Can you please close that?
In between, one question to Dr. Narinder.
Please go ahead, Dr. Soumya. Please go ahead.
One question to Dr. Narinder.
Yeah, I'm listening.
It is from Dr. Amber. Which pain questionnaire you are using in the practice?
So we can go for the brief pain inventory, BPI. That is short, and we can complete it very short in the very short period.
Okay, thank you.
Yeah.
I think in the meantime, we perhaps switch the speaker to Dr. Laxmi Vaj, ma'am.
Okay, sir. Okay.
Ma'am, you please do not feel. I'm sorry for the glitches.
Very No problem at all. Please go ahead.
Martin, please make Dr. Laxmi ma'am the speaker presenter.
So now Madam Laxmi Vaj is going to present. She is presently Director, Ashirwad Institute for Pain Management and Research, Center for University Recognized Postgraduate Fellowship in Chronic Pain Management, and Honorary Consultant in Pain Medicine, KEM Hospital and Sehat and GS Medical College, National Burns Center, Airoli. Her major achievements are developed a new etiopathogenesis and an effective treatment regime for CRPS that reverses not only pain but also the disability of CRPS. Proposed a new concept of neuromyopathy to explain motor neuropathy, a vital component of neuropathic pain. Developed a ketamine-based protocol for burn pain. Pain education proposed and developed the curriculum for fellowship in chronic pain medicine to the MUHS. She was awarded Best Researcher Award in 2015 at International Conference on Recent Advances in Pain, and she has 100 international publication, and she has written 10 chapters in textbooks. And her topic is unusual treatment of cancer pain. I request Madam Laxmi Vaj.
Okay, good morning everybody, and thanks Dr. Anurag for giving me this opportunity to share my thoughts and views. Now I'm speaking about unusual treatments in cancer pain management. And in 2003, I started using dry needling in patients who had failed to respond to usual interventions. And so I realized that unusual treatments require unusual concepts. So in this presentation, I am going to speak about 3 concepts. One is that neuropathy involves motor nerves as well. And concept 2 says visceral pains express themselves through the body wall muscles by the process of referral. And the concept 3 is Botox in low doses determined by our experience of dry needling, ultrasound guided dry needling, relieves cancer pains very effectively. Now, neuropathic pain in cancer is, neuropathic pain itself is defined by Treed et al. As pain arising as a direct consequence of a lesion or disease affecting the somatosensory nervous system. Somatosensory means the nociceptive system, the ascending and descending pathways associated with the nociceptive system. And it specifically excludes, in this article, they go on to say that this is meant to differentiate it from muscle pain mediated by nociceptive afferents from muscle. I believe this exclusion has made life very difficult for pain patients. But if we look at the pains from a different perspective, motor nerves are equally affected. They are nerves after all, leading to neuromyopathy, what I call as neuromyopathy. Thus, neuropathic pains are actually neuromyopathic pains. I call it neuromyopathy because it's not a passive involvement of just the motor nerves. What the involvement of the motor nerves causes lasting changes in the muscles. The motor nerve disorder expresses itself through myofascial pain syndromes. Unless this muscular component is addressed, pains will persist. And these muscle pains are responsive only partially to medicines, not very responsive to opioids, more responsive to neuromodulators, really. But they are exquisitely responsive to ultrasound-guided dry needling. So there is some literature support for this. Major myofascial pains in head neck cancers, in visceral pains and neuropathic pains. These are the publications by other authors who have spoken about myofascial pains in cancer. Unfortunately, whenever somebody talks about myofascial pains in cancer, it is concerned and considered as something secondary, and it is dismissed. But when you think of neuropathy as neuromyopathy, it becomes the primary modality through which the pains, neuropathic pains, express themselves. So now, what present interventions do we have? None of the present interventions like the stellate ganglion block, celiac plexus block, hypogastric, ganglion import block, or advanced interventions like intrathecal drug delivery, RF ablation of ganglia and nerves address the muscle. Hence, cancer pain continues to remain a major problem. Dr. Narinder was talking about the ideal treatment which eliminates or reduces pain by 50%. This appears to be quite a difficult goal without the side effects coming in with medications and these modalities. Hitherto, classical symptoms of neuropathy have remained refractory to the treatment because myofascial syndromes has not been linked to neuropathy. All these symptoms routinely and invariably respond to ultrasound-guided dry needling. I'm talking not about 1 year's experience, I'm talking about 15 years of experience of using ultrasound-guided dry needling for treating pains in cancer. So now let me explain what happens in this. I'm showing the picture of the integrated trigger point hypothesis by Simmons et al. I hope you can see this. Let me make it big screen. So now there is always a leak of acetylcholine at the neuromuscular junction, which causes miniature end plate potentials. But where there is a myofascial trigger point in myofascial pain syndrome, there is a tremendous increase in the spontaneous electrical activity, leading to lots of miniature end plate potentials, 10 to 1,000 times the normal amount. And what this happens is, with all these miniature end plates potentials summating, the relaxed muscle gets contracted and causes local sarcomere contracture. When there is a contracture, it causes local ischemia, acidosis, local energy crisis. And inflammatory mediators are released that cause peripheral sensitization. And this leads to nociception and pain. And this also leads to autonomic stimulation. Our interventions, which we are all used to, the stellate ganglion and the sympathetic ganglion, they block at this stage. They are treating a consequence of this contracture and not the cause. That is the reason why autonomic blocks work so well for a little while, and then the pains recur. And somatic blocks also have the same problem. You can completely block the pain, the somatic nerve block or a somatic plexus block, but the underlying cause still remains. So I just want to share with you this. I hope you can see this slide very well. Can you see the black dots in all these, in this muscle? This is the pectoral muscle of a patient. Are you able to see? I don't know. Can somebody respond? Okay, I don't know. I'm not hearing. So this is a patient with right mastectomy who had no problem in the breast, but suddenly developed axillary lymph nodes on the left side. And I got these lymph nodes and I documented it. He underwent chemotherapy, and you can see that these facial points have become much bigger with the chemotherapy. And after chemotherapy, MTRPs increased in size. All these respect to ultrasound guided dry needling, and the lady continues to be comfortable 8 months later now. What is dry needling? It is not acupuncture, first and foremost, and it is an intervention that involves the insertion of 32-gauge solid needles into the muscles to relieve myofascial pains. As there is no injection, it is called dry needling. It involves the insertion from as small as 1.3 centimeters needles for head neck pains to 12 centimeter needles for lower limb and other pains. Presently, you say dry needling, it refers to a blind placement of needles, usually practiced by physiotherapists. But the use of ultrasound converts it in completely different ball game, and that's called ultrasound guided drying. It usually we use many more needles than what the physiotherapists use. The physiotherapists use about 4 to 6 needles, max 10. We use about 30 to 50 or more needles, and our needles are longer. And because we have ultrasound, you can see where you are. If the pleura, if the shiny pleura is here, I can advance my needle right into the intercostal muscle. It requires knowledge of sonoanatomy and the ability to steer in the ultrasound guidance. It may be used as a sole modality or as an adjuvant to other neural interventions. So it gives us a lot of mobility in patient treatment. I treat somebody with a celiac plexus block if there is a remnant of pain. Instead of continuing or increasing the opioids, I'll do dry needling, take a reconnaissance of the patient's situation, and do whatever I need to do. So now, here is a video. I hope it plays on your, this one. Can you see this? I don't know. Since I don't seem to be in communication with you, I'm simply continuing. I'm playing the needle, this thing again. This is called a local twitch reflex, a pathognomonics feature of a myofascial trigger point.
Ma'am, we can see you well.
We can see.
So no issues. The video is also visible, ma'am, beautifully.
Okay. Yeah. I feel as if I'm a sole occupant of a room. Anyway, so another thing which you watch, which you can see on ultrasound, is this. You can see that there is a crescendo of local twitch reflexes going on. This is a highly painful neuropathic muscle of a CRPS patient. There is absolute torrent of local twitch reflexes. And the same local twitch reflexes, after dry needling, you can see that all the muscles are quiet except something going on here. But you can see the blood vessels pulsating. And this is what you see post-DN. And this post-DN quietness in the muscle correlates with a very good pain relief. So J. Shah et al., they added credibility to the dry needling by using a microdialysis. They used a 30-gauge needle to be introduced into an LTR, into an myofascial trigger points. This needle, where fluid can be pumped in and pumped out, pulled out, they collected this and checked it for inflammatory mediators. They found all inflammatory soup components increased in myofascial trigger point area. And what they did was, they did it before the LTR, local twitch reflex, in the local twitch reflex, and after the local twitch reflex. And they found that was a fall in the inflammatory mediators of local twitch reflex, active myofascial trigger points. There were no such changes in the normal and latent groups. So now coming to the clinical picture, here is a farmer from the interior Maharashtra after partial mandibulectomy, post-surgery, post-radiotherapy. He's got severe contracture, severe constant aching pain. Every 5 minutes there is a shooting pain in the ear, face, neck. All those dealing with cancer pains will know ear pain is a very usual component of head neck pains. And he had severe motor deficit in the right upper extremity. I will not play video in the rest of time. But what I want to say is, we did needling, dry needling thereafter. But I'll play this video where the patient is explaining.
आता शर्ट घालण्यात काही त्रास नाही तुम्हाला बरोबर आता तुम्ही उचलू शकता.
So the patient is saying that I could not lift it, but now I can lift it. And here he is also saying
हाताला 100% मग 100% मग
100% means 100%.
20% आणि डोक्याचं बंदच झालंय. तर 100
So this is kind of response you get. This was, of course, partially stellate ganglion block, ganglion RF, and then dry needling. This is a patient. She's a cancer survivor with 10+10 pain on the face, neck, and shoulder. She is a survivor, but she didn't want to live because there was such a severe pain all the time, 24/7. She had no voice. So in this girl, I did a stellate ganglion block. I didn't do R because she's got a long life expectancy. I did a block. It reduced the pain to 8/10. PRF of nerves to the shoulder reduced it to 6/10, but she still had a lot of shocks and other things around the shoulder. When we did ultrasound guided dry needling, I'll show the video. These are needles which are very, very tight band, which has improved, but you can see that my needle just does not enter here. It's like rock. Whereas if I were to show you here, you can see how easily it goes. It goes very easily, and this is how it was tight here. So what all the people who have seen patients with radiation injuries to the muscle, you know that those muscles are literally like rocks. Those rocks become very soft after dry needling. So after treatment, since her voice was still little weak, we took the video of her sister-in-law. तो आप जब आए थे, फर्स्ट टाइम जब आए थे, आपको ये ऑपरेशन थिएटर में एक इंजेक्शन दिया. वो इंजेक्शन के बाद कितना फर्क आया था? बिल्कुल, ये देखो दर्द कम हुआ, पर फिर भी बैठे बैठे थोड़ा दर्द कम हुआ. इसके बाद में वो सुई का इलाज चालू किया हमने, एक्यूपंक्चर से. इससे आपको कितना फर्क आया? उसके पहले कैसी थी? बिल्कुल पूरा नहीं रोया करती थी. ये सोचो कि दर्द ही दर्द था, और कुछ नहीं, खाना पीना सब मतलब उसका चल ही नहीं रहता ठीक. घर का काम नहीं कर सकते, नहीं, कुछ भी नहीं कर सकते. मतलब इतना दर्द इतना था कि कुछ. सुई के बाद एक बार, कितने बार करने के बाद कम हुआ? थोड़ा कम हुआ, और एक बार बहुत कम हो गया. 4 बार बिल्कुल गया इसे. बाहर जाती है, सब घर का काम, बच्चों को पढ़ाई सब करती है. आउट मतलब उसको कोई प्रॉब्लम नहीं है, खाना भी अच्छा है. The patient herself. कैसे हैं अभी? नाम बताइए आपका. कहाँ रहते हैं आप? So this was a patient with no voice at all. Now voice has come to them. And this lady, I treated her some 5 years ago, and she continues to be normal. So post-mastectomy pain syndrome is another problem which very, very difficult to treat with our present interventions. This lady had 80. She had severe shocks in this area, pains here. She also had this breast surgery where the breast was angry, red, and swollen and hard. This is probably fairly common amongst the breast conservation procedures. And she had about 6/10 pain in that area, this 10/10. And she had no movement at all in this limb. But after our treatment, which I'll show later what I did, you can see that she's moving her limbs. She's got 90-degree flexion. And see the breast. Compare this to this. Unfortunately, I cannot put it on slideshow. You may not be able to appreciate. This looks very normal. Now, what did I do for this patient was, I don't look at the joint itself. I the nerves that supply the muscles of the shoulder. Here is the musculocutaneous nerve PRF being done in the coracobrachialis. The subdeltoid bursa injection here. The needle is in the bursa, and this is the bursa. This is the radial. You can see this is the coracobrachialis, and just below the artery, the needle is coming here. This is suprascapular nerve, which all of you know. And I also add axillary nerve PRF. The axillary nerve winds around the humerus here, just under the teres minor. And this, you can get twitches also, but these twitches are not good. This deltoid, yes, you get a lot of twitches. Those are to be ignored because these are turbine branches of the axillary nerve. if you next to the humerus and catch the main trunk, whole deltoid becomes quite comfortable. But after this, ultrasound guided dry needling of the same muscles. This is the pectoral muscles and the pectoral minor, pectoralis major, and this is the serratus anterior, which is a very, very important muscle in post-mastectomy pain syndromes. This is the pain that they come as the chest, the intercostal muscles, the triceps, where she was getting shocking pains, the digital flexors, and the deltoid. All these muscles were needled. Thereafter, the patient was very comfortable and she loved us for about 6. Thereafter, she had a course and didn't follow up with us. But for 6 months, she was very comfortable. Now, the second concept about visceral nociception and how the referral to the body wall muscles happen. Visceral nociception forms 10% of all the nociception to the abdominal area and into the what is called as the viscerosomatic organs. These receive somatic input from the somatic body wall muscles, skin, etc. That forms 90%. Since this is 90 and this is 10, this is represented as body wall pain through this viscerosomatic convergence. So this causes severe spasm with sarcomere contracture of the body wall muscles. One example which is very dramatic, which I can give you is in a patient of severe pancreatitis, what do you see? You see board-like rigidity. Where does that board-like rigidity come from? It comes because of the viscerosomatic convergence. It's an instant severe spasm in all the abdominal muscles to give you board-like rigidity, which causes the pain in these patients. But later, in cancer, it is like a board-like rigidity which continues on and on and on. And this causes a lot of myofascial trigger points, taut bands, etc. And these muscles are partially responsible to opioids and also to celiac plexus block. They always respond to celiac plexus block, but maybe only by about 40-50%. And we still have to continue the medications and other things. But if you do ultrasound-guided dry needling, after the celiac plexus block or even without it, these bands and MTRPs resolve. You can see LTRs and deactivate the MTRPs. The pain, stiffness, and sensitization come, and opioid doses go down. More than that, it sort of eliminates the cause of pain in these patients. I have several patients of pancreatic CA who have done extremely well, and also chronic pancreatitis patients who have not looked back at all. They are leading normal lives. So these are the way you get all the muscles get studded with myofascial trigger points. If they don't get pain, what else they'll get? This pain, once it comes into the muscles, is self-sustaining and is independent of the visceral input. Even if you control the visceral disease with therapy or surgery or whatever it is, the pain continues, which all of you are familiar with. The surgery is over, everything is fine, but the patient still continues to complain of pain. That is because of this muscle issues. So, but once you do dry needling, these pains go away. Now, this is another patient I wanted to share with you. This is the back of the patient who's, because of the hot water bottles, she's got severe pain, aside is terminal, and you can see the back like this. But after needling into the muscles of the iliocostalis, the longissimus, and the spinalis aspects of erector spinae, you can see that by, this was supposed to show the 3rd session and the 5th session of the needling. You can see the change in color. She looks like this. This is the 3rd sitting, and this is after 6 sessions. Compare this with this. A lot of changes which come with dry needling, not just pain relief. There are so many other changes which come that it's practically a science by itself. Now, what we do is USGDN of abdominal muscles. This is the out abdominal wall of that lady with ascites, whereas this is another patient where the muscles are pretty normal. And obliques, external, internal, and the transversus abdominis. This is the rectus abdominis. This is the peritoneum, and I am in the quadratus lumborum muscle in the back. These are all very involved. And this is a needle which goes through the iliocostalis, longissimus, and the spinalis. The multifidus is here. So now this is another patient with CA ovary, post-surgery, post-chemo. See that angry back. She has got 5 patches of 50 micrograms of fentanyl. She was so much in pain that I could put only these needles in her. But even with that, she improved. And later I could do a thorough needling of her. And
I went through all the mall for 1 hour before I used to become like this side and colleagues around this no problem. And the water back, the hot water back, the whole year. How is your pain? Very good.
okay, I'll end it here. What she's saying is I'm very happy. But see this again. Changes are something I always tell patients. The same lady, later on her cancer advanced and she was from outside Mumbai. So I convinced her to have an intrathecal pump because I told her, look, you can't keep coming to me for needling. As your disease progresses, your pains will go on. So we did an intrathecal pump and still she had to have these needles because she said, look, the intrathecal pump is controlling my mind. All these pains which were there, you please do needling for me because she knew the effects of needling. So she lived now quite well 6 months after the pump and then she passed away. So vertebral metastasis also. This is a cross section of the trunk. If this is the vertebral body, you have the psoas muscle here, quadratus lumborum here, erector spinae here. When there is a metastasis here, all these muscles become very, very tight. And if you do needling of these muscles, metastatic pain is history. So all these work very well. Trigger injections, dry needling. Dry needling works very well because it addresses a lot of areas at a lot of places, whereas trigger injection can only target one small area. Botox will again help very much. And I have published these results of the pancreatic cancer and post-mastectomy pain syndrome in IJPC. You can find these articles. Now, USG guided Botox injections are very, very interesting and very useful. They are, I can use them in head neck cancer, abdominal cancers, and metastatic cancer. The premise is the muscles are the mediators of pain. And these doses are determined by my USG DN findings. If I find a muscle is very tight, I give a bigger dose. If it is very small, so soft, but painful, I give a smaller dose. So it's a very personalized treatment. This is the literature support for Botox injection in cancer pain. Others have tried it as well. Here is a 59-year-old man. This is my last patient, so I'll be concluding. 59-year-old man with hepatocellular CA, very, very severe, right side of the back and abdomen, unable to straighten up, stand or walk. He's a doctor's brother. Mornings were agony with 10 on 10 pain. He was on morphine and 100 micrograms of fentanyl. But morphine was interfering with his life in a very big way. He was severely constipated and he also had an history of admission for opioid-induced intestinal obstruction. So he was in a situation where he can't take morphine, but his pain is so severe. But he was still on morphine, but he was trying to control the dose. And he also had IVC thrombosis, for which stenting was done, banding for the esophageal varices, and chemoembolization and radiation for METs. So, the works as far as cancer treatment was concerned. And here was a situation where I could not really go and do a celiac plexus block through that liver. So as a result, I gave him Botox into the erector spinae muscles, where his major pains were in the erector spinae, spinalis longissimus iliocostalis, into his abdominal muscles, external oblique, internal oblique, and transverse. Very important to address this transversus abdominis. The distal muscles here, as well as the rectus abdomen. All he did extremely well. He had pain relief on his right side. But the left side, I had not focused too much because he had no at all. I had balance on the left side. But he developed pain after we did the right Botox and the left side also. But needling, he responded much better. All these pains went away after. See, ultrasound guided dry needling post Botox does a lot of fine-tuning of leftover pains from Botox. So he's going to office and he'll talk out. He's off morphine completely and he's to be off. He continues with 25 mics of fentanyl. And here is his video where he's talking about how he is.
I was diagnosed with liver cancer in May 2018. Despite the serious diagnosis, I could manage my daily routine fairly comfortably after undergoing targeted treatment for the cancer. I was putting in a full day at the office and even driving myself to work and back. However, around September 2019, I started to experience excruciating pain. The doctors were of the opinion that one would have to manage the pain through medication and to learn to live with it. I was practically bedridden, and the morphine I took for the pain caused extreme discomfort. Fortunately, we knew of Dr. Laxmi, and she suggested Botox treatment to manage the pain. A few sessions of dry needling were also done. This combination reduced my pain to almost zero, and I could resume work again. I cannot thank Dr. Laxmi enough for getting me back.
So basically, when you give Botox, it's not like I also do Botox. It is on the concept of myopathy. Once you understand part, then Botox becomes a logical, but the doses are not the usual doses of Botox, but something very small. So I have conveyed the importance of myopathy to you, not with the international definition of neuropathic pain. Thank you very much.
Thank you for the wonderful session, ma'am. Dr. Vinay, please. Dr. Vinay, you are only in the that mode, listening mode. Dr. Vinay, can you listen? I invite Dr. Madhuri Lokapur, ma'am. Ma'am, please try to Martin. Yes, ma'am, you are presenter. Please log in and do the sharing of your screen.
One question is there: how many sessions normally needed, and how to determine the number of sessions for dry needling?
See, questions are usually first session may not do much. Within 3 sessions, they are all definitely they'll give you positive feedback. Whether it is 30% relief, 50% relief, 80% relief, whatever it may be. But 3 sessions are mandatory, and after that, it all depends on how much pain the patient has and how much relief they want. Many of them want 100%, so they continue to come. And usually by 6 to 8 sessions, that lady with the ascites I showed you, he had about 6 sessions and she was completely pain-free. And the hepatocellular CA man had about, again, 6 sessions. But there are some others who more. And you have to understand that this is an ongoing process. The cancer is going on, the MTRP production is going on, viscerosomatic convergence is going on. So as a result, we might have to them later, usually for once we finish about, let's say 8 to 10 sessions maximum, they don't need another session for at least another 6 months or so.
Thank you so much. Dr. Vinay.
Thank you, ma'am.
I think Madhuri.
Yes, she is on. Madhuri, ma'am.
Ma'am, Madhuri. We have I have already introduced you, ma'am. Now I request you to please start.
Yeah, sure. I think I'll whiz through this because after a very path-breaking lecture by Dr. Laxmi Vaj, I think this is a pretty mundane stuff, especially if I understand that my audience today, they have already done their certification course or they're in the process of doing the certificate course. So they are all familiar with various interventional procedures.
Ma'am, just I would like to come in for a moment with your permission. Yes. That this is for the pain physicians who are practicing. This is for the pain physicians who are in the training, and this is for the resident of anesthesiology who are the further and future of the pain medicine. So, ma'am, we are all very much interested and enthusiastic to see your lecture. So, please.
Thank you so much. So, let's start on.
Yes, ma'am. Please go on.
Please, ma'am. Please, ma'am.
Jump into the topic because I'm sure everybody must be hungry by now. So basically, like what Dr. Laxmi and the earlier speaker, Dr. Singh, had explained, pharmacotherapy definitely is most important. However, as a multimodal analgesia protocol, you can combine interventional procedures along with pharmacology to give much better relief to the patient. So the advantages are basically persistent and intractable abdomen because abdominal is where we can make maximum impact by going in with our various interventions. It is also most beneficial in managing severe nausea and vomiting in many of these cases. Now, whether it is induced by the disease or whether it is induced by your opioid treatment, it will definitely respond to sympatholysis. It helps with the constipation also because blood flow and gastric motility is increased. And thereby, by doing an interventional procedure, you're causing reduction in opioid requirement. Hence, it is very essential to have the knowledge and skills to undertake interventional procedures. You can't do them in all the patients, like inclusion-exclusion criteria if you're applying. Broadly speaking, in coagulopathies and in sepsis, you try to avoid, especially in systemic sepsis, all the interventional procedures. In most of the abdominal procedures, because these sympathetic ganglions are located near the vessels, in case there is any vascular structural abnormality, like abdominal aortic aneurysm, aortic mural thrombosis, or eccentric origins of various arteries, then you should not undertake this procedure unless you have got a lot of experience. Secondly, its effect on bowel motility, though it is good in routine constipation which is caused, in case of bowel obstructions, you should not undertake these sympathetic blocks at all. Anatomic distortion leading to retroperitoneal fat planes is a relative contraindication. So depending, and that's where the CT comes in handy in all these cases. This slide I have borrowed from Laxmi, because Laxmi is the one who used to use a lot of these pain busters initially. And we use these pumps which were mechanically held in a lot of conditions. I still continue to use them as far as my cancer patients are concerned, whereby you can either do a continuous subcutaneous infiltration using morphine, or if you are put in an epidural catheter port, either a port or a regular epidural catheter, depending upon the life expectancy, you can put these patients on such distal pumps and give a lot of relief to the patient. So basically, you don't need to do any implants. It's a much simpler procedure. And the disadvantages are repeated needle punctures, of course. Whenever you see a reddish area, especially if you're doing subcutaneous, you keep changing the location of needle insertion and continue with it. Sometimes you need intermittent bolus dosing and higher maintenance cost per implant, because if he is using it for a long time, because after a week or something, you have to discard and buy the new pump. So there are some of the pros and cons for all these procedures, but this is a very simple procedure and you must use it in your palliative care setting. Now, if we are doing the neurolytic procedures, then two agents which are used most commonly, they are ethanol and phenol. My preference, I 100% in my practice am using ethanol between 50 to 100%. Whereas phenol is basically not available in Pune that frequently. And secondly, the aqueous solution is, you need to prepare it, and it has got no shelf life at all. You have to prepare it fresh. And if you are using it along with glycerin, you will have to get your pharmacy to specially prepare it for you. Ethanol, basically, the mechanism of action is somewhat similar: precipitation of lipoproteins and mucoproteins. The viscosity of ethanol is like water, more watery, so easier to inject, whereas phenol is more viscous and difficult to inject. The disadvantage of ethanol is that you get severe transient pain upon injection, whereas with phenol you don't get it because it is not local anesthetic. The spread will diffuse because it's watery, so it tends to spread a lot, and destruction is more intense. Onset of action is also more intense because of the less viscosity, but at the same time, you have to be very sure about your needle position because it has got a lot of potential of causing damage. Phenol, on the other hand, the disadvantages, it attacks the vessels. So because of this vascular action, especially if you're doing a block in, say, intercostal nerve block, you have to be very sure that you're not inside the vessel at all. Otherwise, it will cause vascular problems and compromise. Again, nowadays, all rollatic blocks we do only under image guidance, never ever guidance. Now, multiple modalities are available with us. In fact, ultrasound is coming in a very big way because of new technology and newer models which are available. And also the operators have learned this technique and they are also very familiar with it. When I started pain practice, even understanding the fluoroscopy was a challenge. So was CT scan. And now with ultrasonography, we have got one more step to climb on the way to learning different techniques. So fluoroscopy is performed, we are all used to it. Anatomic structures, they do overlap. And for me, in cancer, like for usual your musculoskeletal blocks, it is excellent modality because you get real time, you can see how your needle is going ahead. But in cancer, I'll show you some of the slides later on, because you do not see the soft tissue in fluoroscopy, there are chances of your block not getting successful, and also your target may not be in a proper place as per the skeleton. There is a lot of distortion because of cancer itself or cancer treatment and radiotherapy. Ultrasound is pretty simple. I won't say it is inexpensive. This is a chart I borrowed from a publication. It is not very inexpensive, at least in corporate hospitals. You require a lot of knowledge by the operator. Retroperitoneal organs, again, are not very clearly defined. We are not using it at all. And endoscopic ultrasonography, none of us is doing. Mostly the gastroenterology people, they are doing this for us. So pre-procedure techniques, as usual for all the procedures you would do, informed consent after explaining the procedure, and also you have to tell them about how much do they expect about the success of the outcomes. This must be discussed with the patient, and it has to be impressed upon them that this is a part of a multimodal analgesia management. So many a times people think that if you have done some treatment under CT scan or something like that, should take care of the problem. But dosage might be reduced, but you need pharmacotherapy along with this. Informed consent is very important, especially nowadays, because neurolytic procedures are potentially dangerous procedures. And in many of the trained hands, also a lot of complications have occurred. So you have to be very specific about them. Lab investigations, including coagulation profile, must be done. Intravenous access has to be established in all the patients, and when I'm doing sympathetic blocks, I always pre-load my patients with either ringalactate or DNS, because these patients are already malnourished, the nutritional status is not good, they are the intake of water is not so good, and as it is, the poor physical condition is there. So you must take care, because many a times you get severe hypotension after doing these blocks. Patient is already in a prone position, so you may not have time to correct everything. So take this precaution. Coming to celiac plexus block. See, the thing is, there are multiple regional procedures which you can offer to the patient. They can be either coming from your intercostal nerve blocks or even your trigeminal blocks. Various webinars are taking place for different. These are topics by themselves for a webinar. I am going to concentrate today on sympathetic blocks, which form a fantastic armamentarium for a pain physician in all cases pertaining to abdomen. Celiac plexus is one of the most wonderful ones in my practice. If you look at anatomy, you will find that the celiac plexus is located between the celiac artery and origin of the SMA. This plexus can be basically, when people used to say earlier that you should look between D12 to L2, the thing is, for selecting a level under your CT scan, it is excellent. But the variability as per the vertebra is far more. So they are definitely found between these two vessels. So always concentrate on these two vessels when you are taking the slices. Multiple approaches have been explained. We will come to them. But basic approach is that either it has to be retrocrural or it is antrocrural. Celiac plexus basically will supply to all the upper abdominal viscera, including your liver, spleen, pancreas, kidneys, stomach, duodenum, until the flexure. So all these will respond excellently to a block which is done at the correct time. The ganglia, like I explained, it will vary as per the vertebra, but they are excellent as per the vessels. So you must position your needle between the artery and superior mesenteric artery. Remember that the retroperitoneal space is basically a potential space just like your epidural. So when you put some volume over there, it is going to reach your target. So because of the cancer, if the viscera is not where it should be, you can still go to the right place and increase your volume. By adjusting the volume, you will definitely reach the target. Now, there are two things I want you to be aware of. The reason why I went to do these blocks, I personally do all the neurolytic blocks only at guidance. And I want to focus this lecture because this is one modality which is not being fully explored by all the pain physicians. The artery of Adam Kivis, as you all know, is the most important one because the radiculomedullary branch arises and that supplies to your spinal cord. And this arises mainly on the left-hand side in more than 80% of the time between the levels of 9 to 12 intercostal arteries. So whenever we are doing this procedure from the left side, you have to take care that not damaging the artery at all. You have to be sure that it should be far away. Now, when you are doing the procedures under fluoroscopy, you may not see any of the soft tissues. And hence, there are more chances of damage. Even if you go on the internet, you will find that most of these complications, they have occurred under fluoroscopic guidance. And very little on CT, though, I mean, you can never say that it will never occur. So regardless of who's doing it, how much is his experience, some complications are bound to occur. Avoid pneumothorax. If you take the CT, and you all know that we put the patient in the prone position, because of corona, everybody is telling you that put the patient in the prone position so that the posterior part of the lung gets filled up. And in that case, whenever you put the patient prone, sometimes the level where the kidney reaches can come down considerably. So if it is obstructing your field, make sure you are at least half a centimeter below where you can see the lung in the cut slices. If you don't do that, then you might end up in problem because patient is going to breathe in, breathe out, whatever it is, and you will end up with a pneumothorax because of puncture. So like I mentioned, we tend to do these cases to us in the early phase. They come to us much in advance. As you can see over here, these are advanced states in which the patient has come. So like I mentioned, this is the diagram, and either you give a retrocrural because it will involve also the splanchnic nerves, or in the anterocrural, where you are traversing the diaphragm to go in front of the vessel. So now this is how it will look under the CT scan. If you see, you have to always look if there is any lung in the field and take care not to puncture it. Also in the CT scan, you can see where all your viscera is. So there is no accidental kidney puncture. In fluoroscopy, you can never be sure whether you have gone through any soft tissue pertaining especially to the kidneys. So people end up getting hematuria or other complications. So this is retrocrural. Sometimes in advanced disease like this, where the planes are completely disturbed, but many a times what you can do is give intravenous dye to that patient so that the blood vessels stand out. And in that case, it is easier to conduct the block. You can see that the dye is spreading retrocrurally as well as anterocrurally. Then this is complete retrocrural, where you can see the dye is in front of the aorta. In my practice, after trying out various combinations and permutations, I have found that a single needle technique from the left side takes care of the pain. So you don't need to from the right side, because on the right side, you can see that there is IVC. And the plexus anyway is between the IVC and the aorta. So you have to go to the medial side of the IVC. IVC is not as firm as the aorta because it's a compressible venous structure. So when you are putting the patient in the prone, it gets displaced more posteriorly and it might come in the way of your needle. So you don't want to do that, and you don't need to do that, because we know our plexus is located anterior to the aorta. So why do you want to go from the other side? Put your needle only from the left side, put the dye, check the spread of the dye. If it is comfortable, do not put the other needle at all. So if you're reaching in front of the aorta or in the back of the aorta, both positions are excellent, retrocrural or anterocrural, patient will definitely get relief. Like I said, multiple blocks have been done, splanchnic block has been done, but initially I tried all these things. I have not really taken up because I find a lot of security while doing these procedures under CT scan guidance. Lately, people have been doing it from the anterior approach by using ultrasonography, but I do not think it is advisable to go through the viscera, especially at the level of celiac plexus, when you can definitely do it from lateral or prone side. There are some complications which are commonly seen, like orthostatic hypotension, which is temporary. After a couple of days and adequate hydration, this problem goes away. Diarrhea can occur, especially in patients who have been put on various types of diarrheal agents in case they were on opioid therapy. So in these patients, you might get diarrhea that also gets settled in a few days. Rarely, side effects like paraplegia, local toxicity, spinal epidural injections, aortic or vena cava punctures, they can occur. Nowadays, people are not very worried about aortic puncture because there is a block. Actually, they said the approach could be trans-aortic. But I think it's an extremely unnecessary, hazardous procedure, and you should never undertake it. And you don't have to if you are using CT. Retroperitoneal hemorrhage can occur because there is high vascularity in cancer patients with advanced tumors. Visceral organ injury, particularly kidney or pancreas, can occur. Pancreas if you're going anteriorly, and kidneys if you're going posteriorly, can occur. Multiple vessels you can traverse, especially if they are displaced. And pneumothorax, like I mentioned, you may not, when you select the level, the lung may not be in the field. But if the patient is taking deep breath, if he is moving around, then you might cause inadvertent pneumothorax. Next possible block is the superior hypogastric plexus block. And from large bowel onwards, you have superior and inferior hypogastric plexuses supplying to the organs. As you can see over here, the superior hypogastric plexus is located between L5 and S1. However, after the bifurcation of the aorta, you should start coming down. This is not as specific like the celiac ganglion because it's a diffuse a network of multiple nerves in the superior as well as inferior plexus. So you have to just ensure that the drug is spreading across over here. Now this block, I always do it anteriorly. The reason is because it is not two-dimensional. This block is three-dimensional. And therefore, you have a lot of problems coming up while doing this procedure if you're doing it posteriorly. Posteriorly, you can place the needles, but as you can see, the needle has to medial and inferior and anteriorly. So it's a three-dimensional block. So if you're doing it under a fluoroscopy, then you can definitely reach your target, but slightly difficult to maneuver because the L5 vertebra and your arch comes in the picture, and therefore you may not have enough space to move around. So I have found that for superior hypogastric plexus, going anteriorly, because some loops of intestine you are traversing, but patient, if he has already gone loop, so the bladder does not come to the picture, and this you can definitely take care of. There is a small chance because if there is, and also make sure that the bowel is clean, give some bowel preparation the night before so that patient does not have gases or fecal matter filled up in the bowels. And if there is something left, so far there have not been any problems whatsoever, and you are using alcohol which is almost 75 to 80%, so you don't need to worry about the infection. The alcohol will definitely take care of it. That's how I explain it. So now this is your target. So when you are hitting on the lower part of L5 vertebra, your dye will spread and your lesion will be there on both the sides. As you can see, when you have put the dye in, it goes on both the sides. So this is indicative of having an excellent block. The last one is the ganglion of Impar or ganglion Walder's ganglion, and it is a solitary one instead of going bilaterally placed, and this will take care of pain sensations coming from the perineum, the distal rectum, anus, distal urethra, and the third of the vagina. And this ganglion is located in front of the sacrococcygeal junction out here. So earlier, people were doing all kinds of approaches. Like they used to use a curve so that they could go through the anococcygeal ligament and reach this. So this used to be one of the approaches. Under fluoroscopy, people are using needle insertion through the disc between the sacrococcygeal junction. However, again, if you go through, this is how I used to do it earlier also, like because we have done it under fluoroscopy guidance, but now I find that the approach is far superior if you go through the CT guidance, and the space is pretty minimal if you see here. So it is very easy to end up into rectum itself if you are not very careful. So I go through lateral. There is no pain because I had seen a couple of patients who had severe pain in the coccygeal area if you go through the disc between coccyx and sacrum, and that causes huge amount of new pain altogether. So this is how we enter, and we make sure that single needle. In my practice, I had that under CT, if you put one needle, single needle is more than sufficient. If you see how the dye spreads at multiple levels, because it's a free space, you can see that the dye is spreading on both the sides with the single needle approach, and the needle is so superficial, it is not going into any of the viscera. You have a very nice spread of the dye. This is just 1 cc of the dye. So you can imagine that you have put in 5 ml of your neurolytic solution, patient will definitely get pain relief. Various regional depending upon where the patient is having. So if there is upper head or mandible or CA tongue or something, you can use various blocks like trigeminal ganglion block. For lung cancers, we have used intercostal nerve blocks. So it is beyond the scope of 15 minutes to explain all sorts of blocks. But Dr. Sarita said that we must mention some of the major things which we are doing. We also mean that she has put in the pumps. Of course, the pump implants are not doing very well, only in some patients, that too very affording ones. So this was one of my patients where we did it because he had tumor and not taking enough chemotherapy. So in this patient, we put in the epidural, we put in the spinal catheter, keep it under fluoroscopy continuously in AP and lateral views to make sure that it has reached the target. You have to create a passage between the various connectors and then make care that it does not puncture accidentally. Create a pocket into the anterior abdominal wall and implant the pump and suture it. I'm just rushing through this because we should have a complete webinar topic on pump implants. Always there should be checked on this thing under fluoroscopy to make sure that you are in the right position. Like this particular patient, he could not lie flat. So while doing the refills, we had to make it in almost sitting position for this patient. And he had excellent pain relief once we had put this in. The advantage is that you can also put in local anesthetic with your opioids to do more analgesia and reduce the opioid dosage. Now, IDDS is not without complications. Long-term granuloma might be there. Some mechanical problems like catheter kinking, fractures, leakages, catheter migration, CSF leak, all these can occur. You have to take care of infection in a huge way, especially when you are doing your refills. Make sure that they are done in proper setting. And medication side effects, they may not be limited to, but pruritus, nausea, vomiting, whatever opioids have effects, they would definitely be coming. So you have to take care of all these things. Thank you very much. And I must thank Dr. Anurag and ISPC office to include me in this Gurukul 8th webinar.
Thank you very much, ma'am. It was an excellent talk, especially about the complication of celiac plexus and anterior approach about the superior hypogastric. Now, next speaker is Madam Sarita Singh. She is presently working as a professor, Department of Anesthesiology, KGMU, Lucknow. She has done MBBS and MD from KGMU, Lucknow, and PDCC from BHU, Varanasi. And she has done. And her area of interest is cancer pain and palliative care. And her topic is about role of palliative care in advanced cancer patients. I request Ma'am Sarita to start, please.
Thank you, Dr. Vinay. Good afternoon, everyone. I'm going to present the topic, role of palliative care in advanced cancer patient. As all of you know that cancer is a leading cause of death in the world. And there are many curative treatment as well as palliative treatment. So palliative care is a health specialty including both philosophy of care and organized, highly structured system for delivering care to the patients and family who are suffering with a life-threatening illness from diagnosis up to the bereavement. So main aim of the palliative care is to relieve the symptoms and improve the quality of life and even death also. So it helps individual by addressing physical, psychological, social, spiritual, and practical issues, and it prepares the patients and family for the life closure, dying process, and cope with the loss of grief during the illness and the bereavement. These are the data which were presented by the WHO. According to this, the new number of the cases, cancer cases in the India is 11 lakh, and the number of deaths is 7 lakh approximately. And these are the cancers, percentage of the cancers which are occurring in the India at different places. The epidemiology of the palliative care: approximately 1 million cancer patients in each year are present, and 80% of all presenting in third and fourth stages of the disease. Among them, 2/3 are incurable and need palliative care, but less than 1% receives palliative care. 1 million of patients experiencing cancer pain every year, and less than 3% are receiving pain relief. So if proper palliative care is established, approximately 4 million people will be benefited from the palliative care according to the WHO. So in the history of the palliative care independently was started from the Gujarat under the Pain and Palliative Care Department of Anesthesiology. And in 1994, ISPC was registered as a trust society in the March 1994. Now at present, instead of many hurdles, there are many states of India and NGOs who are involved in the developing very good palliative facilities. But still, due to dense population, it is very difficult to provide facilities to all. Estimated number of patients who needs palliative care are about 6 million per year, but less than 1% are getting these facilities, and less than 3% cancer patients are getting pain. Why this failure occur? I am audible, Dr. Anurag? Hello? Hello?
You are, ma'am. You are audible. Very well
Okay,
audible.
okay. Why this failure occur? Because there are lack of awareness, lack of health personnel, lack of education, lack of availabilities of drugs. These are the reasons why, due to this, we are not getting the adequate palliative care in India. And seeing these conditions, WHO recommended that there will be government policy in which there will be easy government policy and easily applicable, and multiple education and training should be done in multiple places, and drug availability should be easy. So according to the WHO, the palliative care is an interdisciplinary approach which improves the quality of life of the patients and their family who are suffering with life-threatening illness through the prevention and relief of the suffering by means of early identification and treatment of pain and other problems like physical, psychosocial, and spiritual. Who needs palliative care? The many patients of non-malignant also, and as well as malignant patients, need palliative care. How palliative care differs from the hospice care? Both palliative care and hospice care provides comfort, but palliative care starts from the diagnosis till the treatment, and hospice care begins when the treatment of the disease is stopped. What are the benefits of the palliative care? As well as curative treatment of the cancer patients, palliative care has equal benefits for these patients because it can conduct systemic system evaluation by using standardized tools and documents like Edmonton Symptom Assessment System for the cancer pain evaluation, case questionnaire for the opioid tools, and it provides regular assessment of emotional distress. It gives screening for delirium and optimization of regular opioids by significant questionnaires. So palliative care have access to an interdisciplinary team capable of rapidly managing physical, emotional, social, family, and spiritual problems. This is the new model of the palliative care. In the new model, the palliative care starts from the diagnosis till the bereavement, including death. Actually, who needs the palliative care? The first and the most important case is the advanced cancer patients. They need the palliative care, and these are the patients who also needs the palliative care. So this is the guideline of the palliative care, which was published in 2018 in the Indian Journal of Pains. And according to this, the first guideline, the first is the structure and process of the care. Structure, the forming of the team, including doctors, nurses, social workers, volunteers, and counselors. And the second one is control the physical aspect of the patient, and psychological aspect of the patients, and control social aspect, spiritual, cultural, care of the patient nearing the end of life, and the most important is the ethical and the legal aspects of the care of patients. Comprehensive palliative assessment is included in 4 domains. The physical pain, easily treated by the medical model, which already our speaker had told the different modalities of the treatment of the cancer patients. And apart from this, the psychological pain often manifests as the depression, anxiety, or agitation. Social pain, there are results from the change in relationships, and spiritual pain. Why I am dying? These are 4 very important domains in the palliative care, which you have to see the patient when you are going to treat the cancer pain and cancer patients. The palliative care is a holistic approach. in the spiritual, physical, psychological, and social, these are the points you have to cover. Because time is very short, so I'm going fast. The most common symptoms in advanced cancer is the pain, which we have discussed already. Apart from this, the dyspnea, nausea, vomiting, delirium, constipation, malignant obstruction, and severe hemorrhage. These are the very common symptoms which we are going to manage in the palliative care. The dyspnea treat the cause, and apart from them, the palliative process which we can do is the general support the patients, change the position, give the fresh air, explain the patient, and you can use a low dose morphine, anxiolytics, nebulize. You can do nebulization and pick up the secretions and diuretics and supply the oxygens. Noisy breathing. This is very painful symptoms which comes at the terminal age of the terminal time of the patients, and this is very distressing for the relative. Explain the relatives very well that is this noisy breathing is due to the collection of the secretions in the pharynx, and change the position of the patients and prevent the secretion by giving anticholinergics like glycopyrrolate, atropine, etc. Another cause is the nausea and vomiting, which you can buy these drugs. And severe hemorrhage, you have to explain the family first that it may occur at the last stage of the cancer patients, and this is the terminal event. You have to be prepared for this incident and make the privacy and cover that hemorrhagic area by dark color cloth, and give the midazolam, lorazepam, and give the emotional support to the family members. Seizure is also very common in the patients of the cancer in last stages, which you have to manage by medically or in the palliative care. You can be assure the patient's family, give the midazolam, make the cool and calm patient, and secure the airway. Confusion is also a very important stage in the last stages of the cancer patients, and you can treat it by haloperidol, olanzapine, lorazepam, etc. Restless and agitation, you have to ensure the family members, and sedation is needed in these cases for the patients. Hypocalcemia is another cause in the terminally ill patients, which you have to treat by the these fluid replacements, bisphosphonates, etc. Constipation, it is also a very important symptoms in the last stage of the patients, which you can use by the laxative agents, and management by the enemas, many suppositories you can use, saline rectal wash you can use, and common care in the bedridden patients. In the cancer patients in the last stages, you have to care about the oral situation of the patient, skin care, bladder, bowel, perineum, ostomy care, wound care, and lymphedema care. What is the team of the palliative care? It is interdisciplinary team care, which includes doctors, nurses, social workers, counselor, home health aides, bereavement counseling, dietary counseling, physical therapy, occupational therapy, speech therapy, and investigation drugs, and durable medical equipments and supplies. This is the work of team which we have to see. Legal aspects of the palliative care is autonomy, respect for the person, what type of life or what type of dead person wants, you have to do care this, and doing good protecting best interest, always do best for the patients, and avoiding all the things which is going to harm the patients in the last stages, and do justice. These are the pictures in which we are giving the training to the family members to see the patients, and these are the various procedures which we are doing in our institute, like ascitic tap, lymphedema management, and fibrous removal. So the conclusion: care of the imminently dying is a best practice in specialist palliative care for all disciplines. Requires broad clinical competencies in the form of communication, assessment, and management of patients and family distress. It requires professionalism, confidence, and a supportive team. Ensures patients' comfort at the level of physical, emotional, and spiritual. Make the end of life peaceful and dignified by care and support. For family, make the memory of death as positive as possible. So we will be fail to cure the patient, but it does not mean that we should fail to care for them and relieve the sufferings. Thank you.
Thank you, ma'am. It was a brief and excellent presentation about the basics of palliative care and how to treat symptomatology in advanced cancer patient. Thank you very much, ma'am. Dr. Anurag, can we have some questions?
Please take the questions. Yes, we can. Because our audience are so patient and wonderful audience. That, they are still waiting in spite of all the technical glitches we had, unfortunately, today. So I hope that they would like to listen to our experts about their queries. Please take them one by one, and I will request.
Few question is to Madam Laxmi.
Yes, I would request at the same time to our eminent speakers to keep their answers short and crisp. So,
ma'am, there is question about the dosing of Botox. One question is about the dosing of Botox in dry needling, and second question is time difference between two sessions, and third question is about the how much needle one can use in a single muscle.
See, the Botox question I was expecting, because Botox is sophisticated. Dry needling is not. So I knew that there would be questions. See, to decide the level of Botox, the dose of Botox, and into which muscles it goes, you need to have a thorough understanding of the principles of dry needling. It is not dry needling as done by physiotherapists addresses the most painful area wherever the patient indicates. Whereas USGDN, the policy will be that if one muscle is involved, its co-activators, co-acting muscles are also involved. So it is not one muscle, but many muscles which are involved. The agonist, the antagonist, the fixator, and so many other muscles are involved like that. So unless you have an idea of why you do what you do, I wouldn't advise Botox to be given by people as a panacea. Okay, somebody's got pain in one area, go and shoot Botox there. That's not the way to go about it. But to have a proper understanding. And the doses of Botox are very small. Let me just tell you, in this man, I used about 100 milligrams in so many muscles, in all the muscles of the back. When I say back, I'm talking about, I'll say spinalis, I'll say longissimus, I will say iliocostalis. And then I'll say multifidus. And then I will go into quadratus lumborum. So, the patient's pain may be just in one area, but you need to go into all these things. So, the dose, as I said, I used 100 milligrams for all these muscles on both sides and also into the intercostal over the liver. So, a simple answer to this, you have to learn the principles of ultrasound guided dry needling before you go, cowboy style into boats. One. Then the second question was, usually how many days between sessions? It's about 4 to 5 days. That gives the patient time to recover from the first session and the muscles to relax. The third question was what? I don't know.
It was, ma'am, how many needles you can use in single muscle?
In a single muscle, depends on the size of the muscle. If it is like a masseter in the head neck, then I may say something like 2 or 3. But then when I do masseter, I'll also do lateral pterygoid, which will go through the notch, mandibular notch. And it will also come from the front here, in front. So it is not like one needle is meant for one muscle. One needle goes through 2-3 muscles sometimes. And so each muscle may receive about 3-4 needles. And again, to emphasize the point about the co-workers, when I say masseter is a closer of the mouth. What opens the mouth is the mylohyoid here. So you need to address that as well. The lateral pterygoid, the medial pterygoid, and the temporalis. All these are co-workers of this masseter. So you need to address all these. So for a small muscle like masseter, maybe 2 or 3 needles. For a big muscle, let us say like in abdominal pain, like the erector spinae, I may put about 15 needles right from P4 down to the sacrum. Yeah, that my answer is over.
Okay. Thank you, ma'am.
It's a different science, actually. You see, we are all used to nerve blocks, which are a specific thing. You go to a nerve block, give this much dose and get out. But muscles are dynamic organs, and this is a totally different concept. So it is the concept you have to get rather than what exactly to do.
Okay, thank you.
Thank you, ma'am.
Wonderful answer.
One
Take another question.
One question to Dr. Sarita. Is that hypocalcemia you were treating with bisphosphonate, or it was not understood properly because it was hurriedly taken? Madam Sarita?
Yes, in hypocalcemia, first you have to correct the cause. What is the cause of the hypocalcemia? Correct the correctable. And then you have to replace the fluid and use this bisphosphonates. You can be used bisphosphonates after doing this electrolyte testing.
Okay, ma'am. Okay. Thank you, ma'am. Thank you very much. And to Dr. Anurag, there are some people are asking about the PDCC courses about the pain management.
Yes, actually this society, that Indian Society of Pain Clinician, is formed of people who are either formally trained into the pain medicine by doing their PDCC, PDF, PDF and DM courses. And it is a great news for all of us that DM pain medicine and the FNB pain medicine has been notified by the MCI also, has been recognized by the MCI also. And most of these eligibility in these courses are MD and DNB anesthesiology. So that is why we have started this initiative of information and awareness among the anesthesiology residents and the people who are interested in doing these courses. So I hope that they will find them useful for their to check whether it is their cup of tea or not. And this is a small list of courses we are currently having in our country. That is DM pain medicine, that is PDAF of 2 years at SGPGI Lucknow, PDCC at various places, AIMS. There is one shortcoming in this slide, that AIMS Jodhpur has started PDF in pain medicine from this year only. That has to be included here. This is my mistake. And there are multiple fellowships by Dr. Laxmi Vaj ma'am, Dr. Madhuri Lokapur ma'am, and few other people in the Maharashtra, which are recognized by the Maharashtra University of Health Sciences. And recently, as I have already told, that FNB pain medicine is also there. So this webinar is an attempt to testify the residents of anesthesiology whether it is their cup of tea or not, because it is not necessary for every anesthesiologist to venture into pain medicine, and that is not possible also. But we want to give them a fair choice so that they can make a career choice early in their career. They can choose their career wisely. So this is our small effort for that, and I would like to especially thank all our speakers of today, Dr. Laxmi Vaj ma'am, Dr. Madhuri Lokapur ma'am, Dr. Narinder Singh, Dr. Sarita Singh, and I am personally apologize for the technical glitches you had to face today. And I am really thankful that we have got audience from across the world, ma'am. You would be happy to know. I can see many people from the outside India, as well as a lot of people. Most of our audience is from our India only. And I am so thankful to them that they, on a weekend, on a Sunday, they have spent so much of time because of the content you all have brought, and they are not disappointed, I must say. So this is all, ma'am. If you want to chip in, ma'am, Madhuri ma'am, or
Yeah, actually, I just wanted to clarify what Dr. Sarita has very nicely elucidated.
Yes, ma'am.
Hypocalcemia can be caused by bisphosphonates. So actually, you can correct it by giving calcium gluconate as an emergency measure, and also make sure that the patient is receiving vitamin D3, parathormone replacement, and regular calcium, and then that can be brought in. And this problem occurs especially if the kidney function is not normal. So
yes, ma'am.
that should be
One
done.
more.
I think question was
One
about
more
the
question.
hypercalcemia, or it was it about the hypocalcemia?
It should be for hypercalcemia.
Okay,
It is
okay,
treated by bisphosphonate, and it is corrected by, and hypercalcemia cause the
Yeah, so
pain.
Dr. Sarita ma'am was also telling about the hypercalcemia only, because I think.
I think.
Hypocalcemia.
Okay.
And
That's great.
Hypocalcemia.
one question ma'am has written. Ma'am Lokapur has written the Sudhakaran, and another question is there for Ma'am Lokapur is there. Is there any difference in duration of pain relief in celiac block in CT guided or fluoroscopy guided? Ma'am Lokapur.
Actually, if you have hit the target, there should not be any difference between the the duration of pain relief once you have reached the target. But like I said, in advanced cases, under fluoroscopy, you are never sure about your target and how much it has reached. So CT is the most definitive for that. So I would suggest
something here.
everyone should use CT.
May I add something here?
Yeah, ma'am, please.
Like what Madhuri said, see, you will reach somewhere with fluoroscopy or with CT. It's the accuracy with which you reach, number one, and number two, the safety features. Especially when when you are doing something like the celiac plexus block or even the Gasserian ganglion, if you do it under CT, you will realize where all you can wander, which you will not understand when you do it with fluoroscopy. So I feel CT is a much safer one, but the cons of it is that you are doing probably a dangerous block in a CT suite, which is not as comfortable as an OT.
Ma'am, I would like to chip in here also about the same question. I certainly believe and trust that CT is certainly much more accurate, much more safe. But at the same time, ma'am, it is logistically very difficult for anybody who is doing pain medicine in the private setups. Like we know many of our friends are running their own pain medicine centers. So it is almost impossible to have them a CT scan for the sole purpose of doing the celiac plexus rhizolysis or any other rhizolysis for that matter. At the same time, ma'am, Siam is much more versatile, though slightly more on the riskier side. So there is we need to find the risk benefit ratio and doability and feasibility of the things. So this is my just submission.
So what you can do is you can have a look at the patient CT scans before the procedure. If you think that
Yes,
this
ma'am.
is, then I would suggest that you do get attachment to nearby hospitals with CT scan and do it. Secondly, in my setup, what I find is CT is cheaper than doing it under fluoroscopy in corporate setup, because we are charged for OT time, we are charged for monitors, for O2 and everything. Whereas in a CT, they charge me just 5,000 as a block this thing, and we do. Touch wood, I have not had any mishap going on, but I don't want to jinx myself. But yeah, and when you're doing it often, that staff gets trained. Certainly, we do not need any radiologist because we know our anatomy of pertaining to our blocks. If you know it, you don't require a radiologist, so those charges are also taken. And getting an appointment is much easier in a CT scan. I go on a wait list because surgeons are hogging the Siam. So I guess it depends on your situation.
Yeah, where are you working at? Like at my place, ma'am, at Dr. Sarita's place, Dr. Vinay Somya's place, I believe, that we all have our dedicated pain medicine OT. We have our own Siam, we have our staff. So for us, it is much more versatile to use the Siam fluoroscope. And one more thing, ma'am, academically also, I believe that there is perhaps no study, head-to-head study between the CT scan versus fluoroscopy comparing the results as well as the adverse effects of the two techniques. So this is just a belief that CT is providing more accurate, which is theoretically true, but unfortunately, I haven't gone through any study which has compared the adverse effect reduction of adverse effect with the use of CT. So
I think the
that's
reason
it.
is because under all the interventional radiologists are doing it under CT, whereas the pain physicians are doing it under fluoroscopy.
Yes, ma'am,
Therefore,
yes.
all the papers, if you check the papers, they are all published by interventional radiologists and not many by pain physicians. Even in our textbook, they do not mention the CT guided thing to a large extent.
Yes, ma'am,
Then we
because pain
should all
physicians
take the
usually do not
initiative for
prefer it.
publication, I think.
Pardon?
So I will request
Dr. Naren?
Madhuri ma'am,
We
if you
should take
can
the
just
initiative for
pull up
publication.
your data, and then probably we can have a study from pain physician as well, and then we can have a at least some benchmark for the this thing
Yes, yes. This is good
complication rate
idea.
and everything.
Yeah,
Yes,
I
this is a
fully
good
agree.
idea, ma'am. Huh. We need to generate as a society. This is our responsibility to generate the evidence. And in India and also from multiple parts of world, lot of work is being done, but without getting published. So I think that with the help of you seniors, with your guidance, we will be able to generate our own data, our own experience, because everybody's condition are different, every city's condition are different. So we have to find the middle ground for the larger good. Welcome, Dr. Niranjan sir. Happy to see you. Hello.
Yes. So you just came to grill us, is it? You were not there during the lecture.
Sir, your speaker is off. Sir, mic is off, sir. You can only hear. You cannot speak. So you please again check it and do it. Doctor, is there any question?
No, sir. All has covered almost, I think.
Okay. Dr. Narinder,
I
Yes,
wanted
ma'am.
to add one thing.
Please.
Yeah, ma'am. Yeah, ma'am. Please. Please, ma'am, please.
See, I don't want to discourage people from doing dry needling by saying that you need to use the co-acting muscles, etc., etc. Let them just start wherever it is, and they will find their own way. And if they get doubts, I'm always there, or people trained by me are always there. But somewhere you start, because this is a simple and safe technique with hardly any risks to the patient and tremendously beneficial. Unless you do it, you will not realize how beneficial it is. And unless you do it, you will not realize the variety of benefits you get.
Yes.
Yeah?
Yes,
I just want
that is a very pertinent thing, ma'am, because in our country like us, it is a very cheap modality, economical modality, and which can be done without any sophisticated equipments.
ultrasound. Ultrasound.
Yeah. Ultrasound you suggest, ma'am, but ultrasound is fortunately available at most of the center, even in a very small place.
Yeah. And in most areas, ultrasound can be sort of waved, but not in the chest. Chest and neck, you should not, you have to use ultrasound.
Yes.
Once you learn the anatomy, there is really no need. But to learn the anatomy, the learning curve is there.
That's enough.
My compliment, Dr. Anurag,
sir.
for a very good
Sir,
session.
sir.
Cancer pain, very good session, very informative.
Thank you, sir. That is all because of our panel of speakers and Dr. Soumya. That we have brought the four corner of the country for our benefit.
I'm going to cover 4 corners of the world also, by the way.
Sir, you are here with us for that.
Thank
you, sir.
Sharing my thoughts on ceiling flesh block, very well done. Now you can do fluoro guided stages. Ultrasound is already in there. So people
Yes,
doing
sir.
ultrasound guided, and we've been doing CT guided, like she said, Dr. Madhuri, the
Yes.
radiologists are doing more of CT guided work. What I have devised in my place is when I find it difficult or you don't get result in one go, like you're doing fluoro or the ultrasound, I put 3-4 needles under the fluoro guidance in my OT first. I put 4 needles, 2 at the splanchnic and 2 at the celiac. Now let me explain where is end of life care. It's not about the data. It's that you have to give end of life care relief to the patient. Patient doesn't know what is data all about. Patient needs only one thing, pain. So what you do is you put 2 needles at the splanchnic and 2 needles at the celiac. Now with the patient covered with the sterile CT, our CT is just next door. I take my
Okay.
patient to the CT room, do a check CT on the needle, put in a little dye about half ml at each level. The what which I think is the right. If it is transaortic, is the best thing. Or I sometimes do a transaortic by intention at there in the CT room, and that is the best single needle which can give you best relief about the celiac part. Otherwise, you can always do splanchnic. So what I do, maybe it's not in the protocol business. Otherwise, I do both splanchnic and both celiac, and maybe 5 ml each, or maybe 10 ml depending on, or pre-aortic 10 ml and another level 5 ml each. Either alcohol, most likely alcohol, or sometimes phenol, most likely alcohol. And I've kind of never failed mostly, because I'm doing 4 needles and there's no chance for any nerve to escape because of the anomalies and the mass and the surgery and adhesions. The nerves are not in the normal location normally. So we have to keep that in mind. So that's why we get a wholesome relief for these patients till end of life. The most important is to give the pain-free patient at the end of the procedure. Forget about the protocols. That's my point of view. Until you're in study business, doing study or protocol or evidence-based medicine, it's different thing. That's my viewpoint. I thought I'll share with you people.
Yeah, that is actually, sir, the very pertinent
Combining
thing.
is better than doing a solo fluoro ultrasound or solo CT. Combining is always a better option.
Yes, sir. Sir, that is very pertinent point.
They're going to come for one time to you. They may not come back again if you're not giving them relief, and you don't want to have failures. By the way, you are the last the savior. So here you have to really work as you are the expert most, and you are the last person for this patient.
Certainly, that is very pertinent point, sir. But at the same time, sir, we need all kind of we have multiple things in a thali. So your approach is right, ma'am's approach is right, perhaps my approach is also applicable. So there is no single way of doing the same thing.
So the most important thing.
Pain relief is the motto. Ma'am, sir, at the same time, as an educational society, it is my responsibility to convey that evidence generation is equally important. Because because word moves by that. The current system moves by that.
Here, Dr. Anurag, when the evidence we talk mostly the Western evidence. The problem is they don't have the protocol of this kind because of the insurances running their business, So many times you see those discographies are gone, other things are gone which are still pertinent, and they don't do all these things, So the whole point is that is where we chip in, that we have something which we can combo these things and we can produce this evidence. We can start our own work producing evidence. Then
I just requested that thing only, sir. Just before you joined, I requested all the esteemed panelists as well as the listeners of our webinar. I requested the same thing, that our India, we all are doing a good amount of and good quality of work. We must publish our work so that we can generate our own body of evidence. So that is very important. At the same time, Dr. Narinder, I would like to ask you a little bit about one question I have in my mind regarding the use of patches. Like you mentioned the use of patches. What I am seeing and experiencing everywhere, that patches are being used right, left, and center, and not only in the malignant pain but also lot of non-malignant pain. So what is your take on that? Because I have seen there Johnson & Johnson people are also here. They must be listening what I am saying, but they should listen. That they are promoting these patches to the doctors who are not very well versed with the effects and side effects of these patches. They are going to orthopedicians, they are going to physicians, they are going to neurologists, and they are like, I get the patient for cancer pain management in my OPD after he is having 5-6 patches, and they all have been failed miserably because there was no dose determination before they were put. So I would like to hear a word whether these patches should be promoted for the non-malignant. Even I have seen people using them for post-operative pain. So what is your take on this thing?
That's the main important thing, that education, the training is lacking. The physicians or surgeons, they are not having the proper training. So transdermal patches should be given after the stable dose of opioid is calculated in the 24 hours. So they don't calculate. So it's not recommended. Even company people will agree with me that they are not recommended for the opioid naive patient. We have to find the opioid dose first, and then we convert the dose and we give the patches. So for the other thing I am telling you, for these patches are available in the foreign country for the non-terminal cancer pain as well. So they are using for the chronic pain, but in India, it's still not acceptable to use those for the non-terminal chronic pain. So like for the post-operative pain, the people are using buprenorphine patching without knowing that its antagonist-agonist effect will have the withdrawal symptoms of the morphine or fentanyl, pure agonist, which we are giving for the perioperative period. So all three things keeping in mind, proper training, opioid naive patients should not be given patches. Yeah.
Dr. Narinder, I just want to ask your correct state opinion without mincing your words. Are they indicated for the post-operative, perioperative pain? Are these patches preferable for the non-malignant pain, non-malignant chronic pain like low back pain, like knee pain? What is your take on that?
Yeah, that's for non-terminal chronic pain we can use, but we should not opioids first. But for post-operative pain, it is strict no for using all those buprenorphine or fentanyl patches.
Okay.
So as a responsible company, what we are promoting in? We are promoting in chronic intractable pain, that is generally in malignant pain, where we promote to all the pain specialists and to the oncologists and oncosurgeons. And sir, we are talking about chronic intractable pain. We are telling then it is something when in low back pain, only in chronic back pain or chronic rheumatoid arthritis pain, which has been uncured for long time. So in that case, we don't promote in post-operative or we don't promote to physicians or neurophysicians. But sir, I agree with your point where you're coming from, because sir, the number of patches which are available in the market is a huge number of patches available. It's not only Johnson and Johnson is there, but we as a responsible company, we try to educate all the doctors. But buprenorphine is also there. So the competition there, sir, that is where we face this challenge. I agree with your point. And
I
never just standard the benchmark.
Yes.
We try our best that we benchmark. And sir, agreed with again Narendra's point that it is very important that it should not be given to an opioid naive. It should be only given to a patient who is in opioid for at least 48 days, or the calculation should be there. So we really say that tramadol should be given and then you should go ahead with a patch. That is the responsibility as a company we are taking, but there are a lot of other companies which are promoting.
Lot of companies. That is the worrisome part, because few companies are so small that they do not have the global presentation like you. So there are few things going on under the carpet, or I can say behind the curtain, which may prove costly to our society in the later run. So that is the worry of our society as a responsible and niche body of formally trained pain physicians in the country. So
can I say something here?
Yes, ma'am. Yes, ma'am. Bilkul.
One of the things is that I am very conservative about using opioids. But having said that, there are some people who do so beautifully, especially the degenerative disease and the post-laminectomy pain syndrome people. You do everything for them. They have that little pain of about 4, 5 on 10 kind of pain, which responds so very well to a 12.5 microgram patch. So, there is one special population which definitely needs it in non-malignant. That is after we have checked with other drugs, neuromodulators, and with me dry needling, which eliminates most of opioid usage actually. But in spite of it, there are some patients, and you do need to consider, and you do have to give.
Agreed, ma'am. Agreed upon.
Agreed, ma'am. Yeah, fully agree.
Dr. Sarita, ma'am, I would like to ask you about your experience of using tramadol and paracetamol combination in the cancer patients.
First, I used to
you are very much inclined in the palliative care patients. So, what do you think that how should we should follow the WHO ladder? Do you start with NSAID and go to trama, paracetamol or codeine, or then morphine?
Dr. Narinder has said very well that at what stage patient comes, you have to start particular level of the WHO. If patient comes in VAS score 8 to 9, then you have to not wait for the first stage. You have to go for the third and fourth stage. So my experience in pharmacological management in cancer patient, first I would like to start tramadol or a combination of the paracetamol. If the patient does not respond, then I used to like this morphine.
Okay.
But patches, I'm not using patches in the cancer patients. Mostly I'm not using patches.
Ma'am, there is any reason, particular reason for not using it apart from the economy, which is also a major factor?
This is economical, this is very costly, and patients are poor in my institutes, very poor patients comes from the different villages, so they are not affordable. And that's why morphine is cheaper, so cheaper, and it is available from the outsourcing in my institute. So I prefer morphine first. But sometimes when there is any परेशानी कि हमें fentanyl patch use करना ही है या कोई patch use करना ही है, then first I would like to decide the dose of the morphine dose of the patient, then I will jump on the patch.
Yeah, that is very important. Underlying which
deciding dose, I will not use the patch.
Dr. Narinder, you want to chip in?
Yeah, I am catering the patient of high socio-economic status. They are not well versed with every 4 hour taking morphine. They are more comfortable with using that patch. So they are using fentanyl patch. It's equally effective for like morphine.
Yes,
but it
yes,
depends on
it is good. If patient can afford, you can use.
Okay.
Yeah, that's the thing. If patient can afford, then compliance is much better, and patient doesn't have to take repeated medications.
Agreed.
Yeah. One thing is there, whenever the patient is not able to swallow the tablet, morphine tablet, and vomiting, nausea is more, or constipation is much more, then it can be indicated.
Then you
especially
can
in nausea and vomiting.
Now.
Yeah. Patch, fentanyl patch can be added.
See, one more thing is, when you have a patch on of maybe 25 or whatever it is, and you're giving the patient morphine, you avoid the peak and valley effect. There is always a background of analgesia going on from the patch. So they can act synergistically, both morphine and the fentanyl. And also you avoid using too much morphine with the constipation and other issues. So I find the combination works very, very well.
Okay.
Yes,
So,
yes, ma'am. And initially, when the patch is applied for fentanyl, it takes some time to act, and in plasma level, up to that time, we require morphine also.
Yes.
Switching over is important. Like 12 hours is the time the fentanyl patch will take. It's till the time you have to maintain that opioid concentration in the patient. And after that, you can very well decrease the dose. Not exponentially, but gradually, of the oral opioids.
Buprenorphine patch is mostly nowadays it is using for post-reduction.
Okay.
So the
Thank you.
Dose of buprenorphine patch for post-addiction is much higher than the opioid that cancer patient.
It is cancer. It is much more.
Yeah, they are using at least 37.5 microgram patch that is not available in India.
Not
so
available,
multiple
yes.
patches has to be applied for that.
That's great. Dr. Soumya, is there any question? I think everybody must be.
I think everybody is as.
So I once again thank everybody, and I would like to invite here Ms. Meenakshi and Mr. Sutirtho from Johnson & Johnson, who has very kindly supported us in this wonderful webinar. Meenakshi, Sutirtho, are you there?
Yeah, sir, I am over
Please
here.
chip in, so say a word about yes. You can start your webcam also. You can start your webcam also. If you
Can you see me?
not yet.
Hello. Hi.
Hello.
So,
yeah, we can hear you. Yeah, but
we can even see him.
Acha, that's great. That's great. Okay.
First of all, thank you to Anurag sir for getting this topic, and something is very close to Johnson & Johnson. As Sarita ma'am has just shared that there were around 11 lakh of patients every year we are getting for cancer pain, and pain is something which we as a Johnson always are looking, and we are having the bucket of treatment of pain, which is like in terms of tramadol, paracetamol, fentanyl, and pregabalin. So we are always close. This is something very close to our heart. Whenever we always want to treat our patients of and wherever they. So thank you to all the panelists for giving such a wonderful talk, and for more such event with Indian Society of Clinicians in future also. Thank you, Anurag sir.
Thank
So,
you. Thank you.
Ma'am,
Thank you,
you are
Dr.
there?
Yes, I am here.
Okay. Thank you so much, sir.
Thank you, dear. Thank you. Dr. Soumya.
Thank you, all the speakers. Very nice presentation, especially Madam Laxmi. She has told us new thing, and Madam Lokapur, she has elaborated nicely, and Madam Sarita, Dr. Narinder. Thank you very much. Thank you very much, Dr. Anurag sir, for providing the opportunity for palliative care as a topic in this ISP's webinar session. Thank you very much, sir.
Thank you, Dr. Vinay. Thank you very much. Thank you, Dr. Anurag, for giving us the opportunity to share the platform. Thank you.
Thank you very much.
Thank you. One extra thing I want to say, good that you use this platform of Mediviz because it's Indian. Doesn't matter about the glitches. The glitches will get ironed out as we go by. Thank you.
Thanks, everybody. It was a pleasure.
Thanks, everybody.
Thank you. Good day to all.